This is about one of the most misunderstood conditions in mental health, dissociative identity disorder, or DID. The hidden reality is staggering. Over 70% of people with DID have attempted suicide. This crisis happens in plain sight, as DID is often a disorder of hiddenness. Many are high achievers, professionals, and parents, hiding an immense internal struggle that others never see. We will show the real cause of DID, how it affects the brain, and the proven path to recovery. What could cause a person's identity to fragment this way? The answer is not a choice, it's a survival strategy. DID is a trauma-based condition. It originates from chronic, severe trauma in early childhood when the brain is most vulnerable. Faced with inescapable trauma, a child's mind may detach. It's a subconscious mental escape to survive the unbearable. Decades later, the triggers for these states are surprising. It isn't always danger. Sometimes it's the removal of stress. Other triggers include a child reaching the age of abuse or even the death of the abuser, which can release suppressed memories. This shows how the past is never gone in DID. It is an active, living part of the present, ready to be triggered. But how does psychological trauma physically change the brain to create separate identities? The proof is visible in brain scans. Neuroimaging shows key brain areas are different in people with DID. The hippocampus for memory is often smaller, explaining memory gaps. The amygdala, the brain's threat detector, is overactive. It constantly scans for danger, provoking a switch to another identity state as a defense. During a switch, the prefrontal cortex, our center for self-awareness, shows reduced activity. This creates the feeling of being a passenger in your own body. So, trauma doesn't just create a bad memory, it physically rewires the brain for survival. This is the biological basis for distinct identity states. With this biology in mind, let's correct some major myths about DID. What you've seen in movies is almost certainly wrong. Myth 1, multiple personalities. The reality, it's one personality with differentiated self-states or alters that are not yet integrated. Myth 2, switches are always dramatic. The reality, most are subtle. It might look like a mood shift or a moment of zoning out. These switches can happen in two main ways. Possession form feels like an outside being takes control. Non-possession form is a more subtle, out-of-body feeling. The impact isn't just mental. DID is linked to severe physical issues, chronic pain, digestive problems, and even non-epileptic seizures. This paints a far more complex picture than the stereotypes. Now for some of the deeper nuances of the lived experience. How alters appear is not universal. It's shaped by culture. In some places, they manifest as spirits, deities, or animals, using available cultural language. The internal experience can be chaotic. Alters may compel risky behaviors, like speeding or stealing, that the main identity won't remember or understand. Remember the disorder of hiddenness? That secrecy is driven by profound shame, not just of the condition, but of the abuse that caused it. Let's connect these threads. How did trauma, brain science, and lived experience create this devastating reality? The childhood trauma we mentioned is a physical force that alters brain hardware, shrinking the memory-focused hippocampus and supercharging the amygdala. These brain changes explain why symptoms are subtle. The brief shutdown of the prefrontal cortex is a silent internal loss of control, not a performance. With this understanding, that shocking 70% suicide attempt rate makes devastating sense. It's the weight of it all. The memory gaps, pain, and chaos. Seeing this deep, interconnected web of suffering leads to the most vital question. Is healing from this even possible? The answer is yes, but there is no quick fix. The standard is long-term, specialized psychotherapy focused on building safety. Therapy works in phases: stabilization, trauma processing, then integration. The goal is not eliminating alters, but fostering collaboration for a cohesive whole. Therapists use modified techniques. For instance, standard EMDR is unsafe for DID and must be adapted to work with memories without causing overwhelm. And this approach works. Long-term studies confirm that with proper therapy, people with DID show significant, lasting improvement in their daily lives. DID is not a spectacle or a character flaw. It is a complex but understandable survival response to trauma. With the right support, healing is achievable.